already have a pretty good evidence base about the relationship between racism and health, but compared to other things that affect health, that evidence base is really thin. And the great thing right now is that there are researchers all over the country who are taking up this topic and trying to figure out, how do we understand the relationship between these phenomena? And the reason we need to understand, like anything else in health or medicine, if you don't know the origins or the causes, it's very hard to come up with the solutions. So we're learning about the ties and relationship between racism and health. The other area that I think we really need to push on is that racism intersects with other phenomena. So there's racism and gender disparities, there's racism and LGBTQ issues, there's racism and disability. And we often take these concerns as one at a time, but a person of color who's physically disabled faces a really different health environment than a person of color who is fully abled, and then a white person who is physically disabled, and we need to understand those relationships. Social determinants are the drivers of health. Racism is a key, if not the key driver, of the disparities in those determinants. So people who have poor housing or low income or poor education are less likely to be healthy. But increasingly we hear healthcare providers saying, I went into medicine to help people. I can't help people if they don't have a home. I can't help them if they can't afford their medicine. So I actually think it's quite motivating to many clinicians to look more broadly. The drivers of poor health in this country are multidimensional. They're rooted in our economic structure, our political structure, our social structure. No health system, no health intervention is going to erase all of those disparities. Equity is a journey, but I do think it's important not only that we have it as a goal, but that we're realistic about what it's going to take to get from here to there and what the limitations of our current approaches are in getting from here to there. In Maryland, where I'm sitting right now, I would say, as Maryland looks at renewal of its waiver, they really need to think, how many resources, for what purposes can we carve out for population-based interventions beyond the total cost of care model, so that we can tackle some of these, or at least start tackling some of these social determinants.